My name is Robert Marino. I'm a member of the Department of Urology here in Jacksonville. And I chose this topic mainly because I have been with the hope that I could offer patients transperineal prostate biopsy with MRI fusion. And I have done through my career many times perineal punctures of the prostate for different reasons, biopsies, drainage, etc. But there is more technology coming in, and this is a changing field. And there's quite a bit of material. I don't pretend to be an expert in the area. This is rather my quest in trying to move from transrectal biopsies to transperineal biopsies. And I certainly welcome comments of anybody in the audience who might have more experience in the process. I would say that just in general, I'm going to be trying to focus on the technical aspects that I see changing as I talk to different vendors and I see different YouTube videos. There's a large amount of literature regarding the studies that other people have done in executing this by different methodologies. And in terms, there's just an enormous amount of literature that I saw, and I don't claim to be an expert in it. But in general, I would say that transperineal puncture of the prostate is something that is adequately or lends itself for draining prostatic abscesses. It also is being done for brachytherapy, not just the placement of the radioactive pellets, but also the mechanical stabilization of the prostate that sometimes is done during that time. In addition, I didn't think about it before, but I did see an article on placing fiducial markers for external beam radiation therapy, doing it perineally as opposed to what I've been used to doing, which is transrectally. And finally, most of all, of course, prostate biopsy. I thought we could probably take a little bit of time to reflect on the development and how some of the highlights of how we got to where we are now, the highly technological approach that started really back in about 1913, 15, with an excitement there was at that time to using radioactive materials to control prostate cancer. And this was initially by Hugh Hampton Young at Johns Hopkins, and he even designed cystoscopes to carry in some pellets that were fairly big because he was using radium. And he was using more like intracavitary. He was not using transperineal puncture. About shortly after that, of course, I would say eventually Hugh Hampton Young, after a great amount of energy spent on radiation therapy of the prostate, he finally appeared to move on to early detection of prostate cancer and radical prostatectomy, and he championed perineal radical prostatectomy. But about the time that he was starting on the radiation therapy, then Benjamin Beringer was one of the several young urologists that joined the Department of Urology at Memorial Hospital in New York. And they became interested in radiation therapy for prostate cancer as well, but his take was different. Instead of intracavitary, he used, for one, a different isotope. Instead of using radium that has a half-life of 1600 years, he used the first derivative of radium, which is radon, and that had only a few days. And it could be capsuled in much smaller containers and had more favorable decay to work as a radiation therapy. And so what he did was he got these smaller needles and put them in through the perineum into the prostate, and he would leave it there for several hours and then come back and switch it back to the other prostate, side of the prostate. And that would be the treatment, and as needed, as he saw fit or as he saw the need, he would repeat the treatment in a few months. And long after Hugh Hampton Young quit pursuing this radiation therapy for the prostate, Beringer continued, and somehow, as best I can tell, this was not picked up by any other urologists, although he continued, had a long career with it. Any questions? So eventually, this field was taken over by radiation therapists, and it came to the modern brachytherapy, which is done through the perineum. It's a highly, much more precise methodology, and it relied heavily on the developments of ultrasound and many other technologies with the isotopes. But just the beginning of this perineal punctures and interstitial therapy was a urologist's purview. The other thing that Beringer did was he published an article on prostate abscess, treating prostate abscess with transperineal puncture. And the way it came about, as he explained in his article, was he was trying to put a radioactive interstitial trocar into the prostate of a patient, and he found there was pus in there. And so I don't know the details about the clinical presentation of the patient, but he published an article on treating the pus itself, like the infection, by this method as opposed to other methods that were existing at that time. And keep in mind that this was even when it was difficult to do endoscopy. But anyway, I think it was long before we had transurethral electrical resectoscopes. And so that was another thing that he did early. And then he did, after that, work on prostate biopsy. And he had some unsuccessful attempts to develop needles that would work for the prostate biopsy. And there were quite a few people designing different needles to sample tissues. And in one of his later publications, he commented that he was using the needle of Dr. Young. And this drawing here was actually from one of Dr. Young's publications, but it was contemporary of Mr. Beringer. Regarding prostate abscess drainage, this can be done by more than one method. I think the more standard accepted methodology is to do TUR and just drain it from internally. And the other one is to do percutaneous. And of course, transperineal is the closest one. We have had a little bit more exposure to prostate abscesses in our institution. I've seen more than I had seen in private practice. And here, for example, is one patient in whom we did it with ultrasound, but we were placing the drain. We wanted to confirm the position of the drain with fluoroscopy. And this fluoroscopy image is low quality because we lowered the amount of radiation coming out of the fluoroscope to a minimal amount. But the little wire that you see there is a thermistor of the Foley catheter that the patient had. And you can see there a little needle going from the bottom, going toward the prostate. And then after we aspirated some pus, we put a small amount of contrast to see the shape of the abscess cavity. And then that allowed us to put the drain eventually. But this is not the only percutaneous drainage of prostatic abscess that is available. One should keep in mind that radiology also is able to put them in. One of the popular methodologies is to do a transgluteal drainage, as was seen by this patient also at our institution. And it is a longer distance. And as you can see here, it comes pretty close to the rectum in this particular patient. There are some large series that I'm sorry I don't have here to show you, but they were out of Brazil, where there's groups there that have been doing quite a bit of the transgluteal percutaneous drainage of abscesses, of prostatic abscesses. I think that going now to prostate biopsy, I think that one of the things that has been a great advance that is not really, I mean, that we take for granted nowadays, is the development of the proper needle to do it with. And the first transperineal biopsies that I did were done with the TrueCut needle. We called it TrueCut because that was, I guess, the brand, but many other companies made it. But this was really the needle that we all use most of the time now, but at one time it wasn't so. The key of this needle is the principle that it's an obturator that is sharp, that is going to move faster, but it's on a shaft that has a slot here, so that when you push this into the tissue, the tip of it spreads the tissue apart, the tissue recoils into the slot, and then over that obturator slides a sharp sleeve that severs the little thread of tissue into that slot. And that's your sample. And when I was doing them in my residency, even in my prior residency, this was used, the same instrument was used for kidney biopsies and many other biopsies. Because this needle moves kind of slowly, you know, it will shear. The ones that we had were 14 gauge. And this was introduced about 1958. I began to find it in the literature. I think it came out of a company in Germany. But the idea is this plunger here in the back, it has two segments. This plunger is tapped in with your finger quickly into the tissue, sorry. And once you have that obturator in the tissue, and then you hold on to this rear end here and slide this other piece forward to shear the tissue off. And so that was came to be the most reliable biopsy needle. And then the next step was when somebody said, well, if we can just increase the velocity with which you move those two things, then the resistance of the tissue would be greater, and you can shear even a thinner piece of tissue instead of having it wrinkle up and not come out in this specimen. So of course, the obvious, I wouldn't say obvious, but the very astute thing was to put a spring, two springs of different velocity, and we saw these guns come up into the market, and there were some that were usable, and then some that are disposable. And this is just a model of the barred one that is most commonly used in our institution, although ours is a different color and different length. But here are the two springs, the two different springs are pushed with those two buttons, and then here are the triggers that are in green. This technique of we mentioned about free-handed biopsy occasionally can be handy, but most of the time now we do it with imaging technology. But we did have one patient a few months ago that had a PSA of about 1,000, and so I remember looking at all the clinical pictures, felt that he was best served with an orchiectomy promptly, and it was done with IV sedation or small amount of anesthesia in the operating room, and then at the same time, with a finger, we did a finger-guided transperineal biopsy of the prostate, and it came in handy because we didn't have to bring the ultrasound machine, and we were confident that we were going to get, prostate cancer as we did. But I think it's good to be able to feel a needle feel in the rectum where a needle is going toward the prostate. Occasionally it might be helpful. Frankly, nowadays, with all the imaging technologies that are available, then I think this is seldom going to be something that we do. So moving on to now the image-guided biopsies. And looks like I'm going a little bit slow for the amount of slides that I have. I'll try to move on faster. But the big landmarks were when the Japanese Dr. Watanabe made the first ultrasound machine, the transrectal. And a few years later, when they finally put a 7 megahertz transducer and a needle guide that worked very well for transrectal biopsies. Transrectal biopsies had been done as early as 1937, a gentleman from Spain, but this really made it take off. And the main, one of the things that eventually came to be less desirable about transrectal ultrasound is that number one is it does more infection, it introduces more infection than does transperineal. And there's a large amount of literature about this. And also there's a concern about the amount of false negatives, especially the anterior part of the prostate and the apical part of the prostate. The other imaging besides ultrasound that was, of course, revolutionary was the MRI guided biopsy, and the ability of MRI to detect the cancers that cannot be seen very easily with ultrasound. And then to take an MRI study and fuse the images with the ultrasound. And we have one such system here at our institution. It's made by Philips. And the process that usually takes place is a multi-step process that has the MRI study is brought in, and the radiologist will, and our team will go ahead and mark the areas that they see as likely to have a prostate cancer, and they score them according to the high-risk classification, and also they give us a MRI, a PSA density for the volume of the prostate, and then that image is downloaded into the Euronav system, which is the name of our system, and the system will make a contour for the prostate, a computer-generated contour, and also mark the areas, or take the areas that are marked by the radiologist and make them as targets. So now we have one, how do you say, shell that is of the MRI study. Then upon connecting that to the real-time ultrasound, the operator will sweep the prostate in one of two fashions, either longitudinally spinning a longitudinal sweep, how should I say, a longitudinal image that is swept radially or by rotating the ultrasound probe to encompass the whole prostate, or a axial image that is dragged down from top to bottom of the prostate. Both of them will give you a sweep of the entire prostate, and that data is then transferred into the Euronav machine and adjusted in. So the first take is manual by the physician, and then to try to marry these two together, first the ultrasound one is submitted to a few changes. One called segmentation, where the outside border that is assigned by the computer is adjusted, and you feel that you have all the prostate included and not too much of the non-prostate areas included in your outline of prostate. And then there's a process of fusion that takes place. First, we try to superimpose these two outlines in using not just their shape, but also the location of what we call fiduciary structures nearby. The most commonly I see is the bladder neck, because the bladder neck shows up on MRI, the bladder neck shows up on the ultrasound. And so we try to adjust these two figures so that the the two bladder necks are superimposed. In addition, if there are cysts, fluid collections inside the prostate, and they're visible on both images, they can also be used as fiduciary. So you try to match those to have some confidence that you have the two lined up properly. And then finally, the ultrasound, the Euronav software does truly a fusion of these two images and a three-dimensional fusion, which needs to be checked in two different planes. And this will include the targets that we want to strike, and then it'll also have the trajectory of the projected trajectory of your needle that is going to biopsy. And so in our system, it shows up as a bullseye. And so then one is ready to do the biopsies. And in our system, it's a rather freehand process, meaning that we hold the handle and move it and aim it, and we see the trajectory, the projected trajectory of the needle going toward the target. And when we see it in the right satisfactory, then we can pull the trigger and biopsy it. Obviously, there has to be a way to tell where that is going, and that is done by an EM tracker that tracks. It rests on the handle of the ultrasound machine, and the Euronav machine is able to tell by the presence of a field generator. So this is an electromagnetic tracker, and this is a clip, and it goes onto the handle of the ultrasound probe. This is the field generator. It's a square piece of equipment, and for our equipment, but it has it gets fixed to in this case to the table where the patient is laying, and it's ideal to have the sensor or the transponder a little bit in the center of this box. So this is the position that is used for us most, and that I see Philips also in their manual puts out. And here's the field generator, here's the prostate probe, the patient's on their side. And so you have quite a few degrees of motion, because the way, how much up and down you move that probe makes a difference. How much forward and backward you move it causes a little bit of deformation can cause deformation of the prostate a little bit. And then the rotation. The rotation, I would say, is the one that least distorts the prostate, but the other one can make changes. So it is important to be able to look at the images, and if there is a discrepancy, then go back and make an adjustment on the image that was generated by the Euronav, and make sure it is in the proper position. So there's room for a little bit of misalignment to take place, but an experienced person, which I'm trying to become more experienced, is able to correct for that. There are moving this system forward into transperineal prostate biopsies. The company already has a machine out that does transperineal. This is kind of the setup. I know this is like a busy slide, but if you would envision that this is a OR table set up for lithotomy position, and you can see here the field generator lying on its side, as long as it's close to here would be the handle of the surgeon with the handle of the ultrasound machine with the surgeon holding it. This is there's more than one system that uses the motion of the handle of the ultrasound machine to keep track as to where it is with relation to the prostate. There is another approach, which is to minimize the amount of movement with respect to the initial study, and that is this other system from France. It's interesting to me that both of these these systems that are so advanced come from Europe. But this one here is a system that has, for one thing, the ultrasound machine is not a other company like a B&K machine, but it has its own ultrasound machine, the different probes. And it does not have an external field generator and transponder. It does not keep track of the movement of the handle, except it records the position of the handle in one location. So you freeze the handle in one location where you're seeing the prostate, and then with a tap of the pedal, all those functions that I mentioned before that are segmentation and adjustments and trying to couple those two together take place in 3 seconds by the software. So it makes a sweep. It has the probe has a motorized sweep of that when you step on the pedal, it'll sweep at the standard rate, not at the manual rate of your hand, but just at a regular rate in a rotating clockwise, and takes the image of the prostate and incorporates right there the location of the areas of interest. And as long as you don't move it, then that's what you've got. And then it gives you the option of rotating the probe, and it'll show you as you rotate where your target would be. So this is the picture of the schematic of the prostate, and here's the sweep, the mechanized sweep that it does of it. So it's doing all the things that the other one did, but this does it kind of mechanically. And this is the arm that fixes it in place. And it can take the grids, like the brachytherapy grid, if you want to have that kind of an approach to the prostate in many different holes. But it also has a mini grid that is just a vertical array of holes. This can be slid backwards and forwards, and the purpose of that is to keep the needle in view of the longitudinal array that your probe is generating, so you can see the needle going in. If you try that free-handed with the needle not coupled to the probe, it's a difficult thing to do. There's a doctor from Hong Kong, and I'm forgetting his name, I think Chang, I think, but he does them freehand. He punctures the perineum separate from, not coupled to the ultrasound probe. And he says that there's a learning curve. You have to do about 20 cases. But what has become more popular is to do it with this couple here, because the learning curve is smaller and you can see your needle going in. You don't have to you don't have to be so skillful in trying to track your needle and move the probe. Now, anesthesia is another thing that is different here. And it's important because if the patient has pain and they move, then suddenly you may have lost your position of where you thought you were, and the precision that you had for a small lesion may be lost. So the difference in anesthesia is that, number one, the perineum has more pain fibers than the inside of the rectum. And if you use a wider, this kind of array, you maybe end up puncturing more than one time. In addition to that, the anesthesia that we did at the base of the prostate for the transrectals, and here most people are doing a puncture from below and that above the levator ani, and right over the front surface of the prostate, and they deposit the anesthetic there with the expectation that it'll run around and anesthetize the rest of the prostate. This vertical grid that you see portrayed here for this particular company has been a similar result has been obtained with this, has been very popular, and this is called a precision point transperineal access system. And it basically does the same thing. It has several holes and up and down, and it has a rail catcher. And this is the rail here, and this is the grid that you can move back and forth, and then this cannula. And so it's basically the same idea, but this one is a disposable one. And the idea is to insert the cannula through the skin and then run your biopsy needle through the cannula. And you would be able to see both your needle coming through because this is lined up like that. And going back again, this is the other grid. And they have two models of it, one that has these holes here, and the other one has slots on the side, so you can put your needle on the side with a little holder. The thing that I could not portray here because I couldn't tell about the copyright, but there's a big effort to try to puncture the perineum only one time on each side, and therefore have less pain. We talked about this injection here. It's usually done at right above the anus, a little bit to the side, and even with this system here, what I found interesting was some of the expositors that are giving examples of how to do this are still doing somewhat freehand in that they'll move this probe in different directions, but after they move it, they step on this pedal and get a new scan so that they get reoriented. And the idea is that, for example, if you have a grid here, the big grid, you may have some parts of the anterior prostate that are not accessible because the bone is in the way. So therefore, if you come from a little bit lower part of the perianal area and angle upward, you'll still get a tangential view there, but you might be able to get under the bone. The other one is to just tilt the patient a little bit further backward to so that you have your horizontal grid, you still go in and get under the pubic bone. But at the end of the day, you still have to increase the angulation between the pubic bone and the probe. The attempt to puncture the perineum only twice and then put a cannula there and angle it to different parts of the prostate, and that's something that is kind of the new thing that most people that I see that new people are trying to do to reduce the number of punctures. And finally, I would say that there is a new concept of how to biopsy this. We had the systematic biopsies. In addition to the targeted ones, to the systematic ones, the new concept of the systematic one is to go around the periphery in this fashion, like this, and taking into account the anterior fibromuscular area, anterior fibromuscular stroma. And so I think that this is an evolving field, and I'm still accumulating information and trying to learn more about it and understand the different methods. I think that for the residents that go into private practice, they may have options to how they they want to do it. But I think getting a fundamental understanding of the limitations of the system and the general categories, I think is good. It'd be wonderful to have vendors come and demo their system. These are kind of expensive systems, and I was hoping Ali Kazrayan was here and he would talk to us today. He was, as I remember, he was the first one to purchase a system for his own office, and so he has a lot of experience. At any rate, that's the state of my investigation, and I welcome any comments from the audience or any questions that I might answer.
Roberto, thank you for, I'll start out. Thank you very much for a really great presentation. I believe that because we have the in vivo Euronav system and we're hooked in with the Dynacad system and everything, we're really married to that system here at UF. And so to go to another system would be, it would make sense because it's been developed over the last 5 years here. So I think we're married to that system. But the new upgrade of that system does give us capability for perineal biopsies. And we've been working in the process of obtaining that over the last 6 months. But because of budgetary issues and things like that, it's not available to us now. But in the near future, I believe in the next year, it will be. And so we'll be able to make that transition from the operating room to the clinic, and then make that transition from transrectal ultrasound to perineal guidance. And as I understand what this new system is going to give us that capability. And I think that transition from the operating room to the clinic setting, if it's possible for, political reasons and ownership and all that. But I started this back in 2014, and I was doing it in a clinic setting with a little Xanax or something like that and local anesthetic, and so it is possible to do these biopsies, but that was done transrectally. So making that transition to perineal as you like to. So I think all this is possible, and but it's just going to take some time. But a very good presentation.
Thank you, Mark. Well, I think that first of all, I want to thank you because you have mentored me in moving into this field here, and so I've learned a lot from you. And I think that the Euronav with this tracker of the handle, to me intuitively seems to be a little bit lend itself more to the freehand approach. I am kind of surprised to see some of the big freehand proponents still using the Coela system, and I'm trying to understand how they do it, just for my own satisfaction to understand. But I think these are very sophisticated systems, and
it's really interesting that we have Peter Pinto at NIH, and he's a very gracious guy. I came up there and worked with him early on, and he even came down to Lakeland to give a presentation on all this. But it's amazing this technology that they developed there, and I like the freehand system because it really doesn't change much from how we were doing it before, but we have that little GPS system, if you will, that guides us. So it really lends, I like how they do that versus the other systems. So I'm pretty happy with that, and I'm anxious to get this upgrade and see the benefits of that too.
Yes, one thing that surprised me was that when I talked to the vendors that are able to rent the machines, the Euronav machine, they said that they, and I hope maybe you can confirm this, that they require this precision point device to work their transperineal biopsies. And I thought it was peculiar because it seemed like something that you could make one gadget just like this other company did. But there must be some patents and things like that. But they require this one to be used. So it was interesting to me that that we will be using this one once we get our new machine. using the precision point.
So I just have.
Go ahead.
Sorry. Dr. Marino, thank you very much. I have two questions. One is more like an administrative question. Is it really cost effective to do this biopsy in the office? Because each of these biopsies takes about 45 minutes to an hour to do them in the office. And my second question is, when we do these biopsies with one skin puncture on each side, and then we angle the needle to go in different sections of the prostate, are we at risk of missing tissue because we are working at an angle, especially if we go to the more superior or inferior portion of the prostate?
Well, first, administratively, I can say that I saw quite a few reports in the literature of people that were able to do it in their office. But I also saw quite a few that still do it with sedation. But I think a lot of it to me is whether the patient can be comfortable. If you can do your local anesthetic well, that the patient can be comfortable. But it just, I think each office has its own requirements, but I think it does require for example, with our Euronav system, in general, somebody runs the console of the Euronav. It could be a resident, or right now it's our nurses that are trained on that. And somebody runs, the surgeon runs the ultrasound machine. So it's two separate ones. But the other one, the coilless one, is a single console. And I think there's another one out there that also is a single console. So there's all these intricacies, Bazat, that I think is hard to answer that question as to whether it's profitable or effective time-wise. Some people have been able to make it work for them, and that's all I can say. Now, regarding the angulation, I totally agree with you. If you take a single apex at a distance, then and you're shooting like a tangential rays toward the theoretical sphere, so to speak, or a walnut, then you could come at an angle that leaves the base untouched. So I think in that case, you go and get the higher point on your grid and go more horizontal. But I think the whole idea with these approaches that, not the whole idea, but one of the features of it is that you're doing more of these almost tangential but deep into the tissue cuts for the anterior portion of the prostate. And whereas when we stick through the rectum, we kind of poke individual areas of the anterior part of the prostate. And that samples well the tissue posterior to it. But I don't think it samples as well the tissue anterior toward the anterior portion of the prostate. So a tangential one with it deeper into the tissue, I think will sample it better. But I think all these things one has to take into account, and I was offered a gratis meeting with one of the Dr. Gorin, who has some very good YouTube videos out. He used to be at Johns Hopkins, and he was involved in developing this precision point. So I'm going to be asking things like that. You know, you have a single one. The other concern is when you move your needle upward at a different angle, you're not just moving your needle, you're also moving your transrectal probe inside the rectum, okay? And so depending whether you move up or down, that can cause discomfort and cause the patient to move. Now you're not hurting him at the skin, but suddenly you're wiggling the probe inside. So all these are considerations that I think I can't really answer at this time. But it's a good question.
Thank you, Dr. Marino.
So, Bashar, to address the other aspect of the question, is this cost effective to do in the clinic? I'm not sure prostate biopsies by themselves are cost effective, whether you do it in the operating room or in the office. Because remember, once we go to the operating room, the cost skyrockets for the healthcare system. Now we've got anesthesia involved. We are taking the most premium of the real estate, which is the operating room in a hospital, and then the staffing and so on and so forth. Ultimately, we're getting tissue for diagnosis. And therefore, no matter how we slice it, I think if we just look at biopsy itself, it may not be cost effective. But there are two other aspects to consider. One is the mission. I mean, we have to do prostate biopsies and offer it because this is an integral part of any urology practice. And then there are downstream benefits that occur with taking care of these patients, which when you look at the big picture, may become cost effective. I think those are the two ways to look at it.
Yes, thank you, Dr. Balaji. I was more concerned about because if you want to do fusion biopsy in the office, that requires some investment in the hardware. And my question was more towards whether the cost of the hardware justifies doing it with the time that it gets in the office to do that. That was just, I was just curious about it.
Yeah, I'm with you. So the way, if we move this into the office, we clearly move it out of the operating room. So in our case, we already have made the capital cost for the urinary machine. The software update that is required is setting us back by $75,000. And that's what we are negotiating. We are trying to negotiate with the company. And then all these companies now are considering what they call the per-click model. So see, the problem with capital equipment and so on, if our department pays $75,000, the onus is on us. And like any capital investment, the more you use it, more value you get for the capital. And less you use, that means capital is not utilized properly. So we are negotiating. I'm not sure whether it'll be successful or not. The companies don't want the bother. They just want you to sell the machine and move on. But what we are saying is, let's share the risk. We assume that we'll use it X number of times and so on and so forth. Therefore, we can amortize the cost over a period of time, which may be most cost effective and also shares the risk. These are, the Intuitive Surgical is not going into that model because it's a huge capital cost. And we are trying to see whether we can work with these companies to have a similar model. And I think your point is well taken, Bashar. We have to look at the cost and effectiveness, but there are creative ways of handling these financially so that it's a manageable and a win-win situation for everybody.
Thank you, Dr. Balaji.
Any other questions for Dr. Marino? Okay. If, Roberto, any other closing thoughts, Roberto?
No, sir. Thank you very much. I appreciate it.
Okay. Thanks for the presentation, Roberto. It was very timely and contemporary and also very interesting, providing us the historical facts. And having trained at Memorial, I did not know that's where, I know radiation was first given at Memorial at the turn of the 20th century. But I did not know, it's actually 1898 or something like that, very, very close. But I didn't know that interstitial radiation also started over there. So nice to know a little bit about our alma mater. Okay, thanks everybody, really appreciate it. Thank you, have a wonderful week.